Readmission prevention and reduction. The multidisciplinary approach with information technology. According to Graham, 2015, annually, approximately 20% of Medicare beneficiaries discharged from hospital were readmitted within 30 days, the readmission costing approximately $17.4 billion. The patient readmission rate is negatively affecting the healthcare financially. In 2012, Affordable Care Act, ACA, requested the Center for Medicare and Medicaid Services, CMS, to change the policy to penalize hospitals with excess hospital readmissions. As a result, the CMS policymakers launched the Hospital Readmission Reduction Program, HRRP, to look into avoidable hospital readmissions within 30 days of discharge beginning on October 1, 2012. Under the HRRP fiscal year 2012, FY 2012, hospitals with high rates of readmissions within 30 days as compared to the national average for that hospital set for patients with acute myocardial infarction, AMI, heart failure, HF, and pneumonia, PN, will see a 1% reduction in Medicare payment in 2013. Penalties will continue to incrementally increase over the next 2 years to hospitals with excess hospital readmissions, such as 2% reduction of Medicare payment in 2014, and 3% reduction of Medicare payment in 2015. While not all readmissions are preventable, in FY 2015, CMS finalized that the healthcare systems also need to keep track of acute exacerbation of chronic obstructive pulmonary disease, COPD, patients who are admitted for elective total hip arthroplasty, THA, and total knee arthroplasty, TKA, and coronary artery bypass graft, CABG. In addition, in FY 2016 final rule, CMS expanded the measure cohort to include aspiration pneumonia and sepsis to the tracking list. The CMS policymakers believe that the HRRP can help improve patient care and outcomes with cost-effective value-based care. Therefore, in addition to HRRP, the CMS linked the Value-Based Purchasing, VBP, program as part of the Hospital Quality Control. For that, CMS authorized the program to reward hospitals based on the annual Hospital Inpatient Quality Report, which is funded by the annual reduction penalties. A significant amount of research has been done on the topic of readmissions reduction and prevention, and several predictive models for readmission risk factors also being developed and evaluated. The purpose of this project is to develop the right system to fit the assigned medical facility, to identify patients at risk for readmission based on the CMS criteria, to alert the care team that patient at risk for readmission, and place patient into the patient-centered multidisciplinary discharge. Planning to reduce chances for readmission. In reducing the hospital readmission using a multidisciplinary approach with information technology, initially, the goal is to improve the quality of health care of patients for all causes, thereby reducing the 30-day readmission rate. Eventually, the goal is to provide high-level comprehensive care approach to the healthcare system as a whole to improve patient outcomes and satisfactions. Under such circumstances, the issue of hospital readmission reduction is now paramount in hospitals' agendas nationwide. Hospitals are striving to bring their 30-day readmission rates down. The healthcare systems know they have all the data needed in analyzing and identifying the problems and locating the solutions. The data documented in the years has the potential to enhance the visibility of information technology and its impact in reducing readmission rate. However, the healthcare systems also understand that the data documented in current years only captures the patient status and medical aspects of care. It has not been used to reflect the components of healthcare practice as a whole. This abandoned information could very well be utilized to efficiently address the population at risk and readmission risk factors. Therefore, in order to reduce the 30 days readmission rate, information technology should incorporate the multidisciplinary approach. In reducing the hospital readmission using a multidisciplinary approach with information technology, initially, The goal is to improve the quality of health care of patients for all causes, thereby reducing the 30-day readmission rate. Eventually, the goal is to provide high-level comprehensive care approach to the healthcare system as a whole to improve patient outcomes and satisfactions. As a result of the implementation of HRRP and VBP, hospitals are now being held accountable for patient readmissions prevention. Therefore, all hospitals are striving to find solutions. In the agenda for reducing hospital readmission rate, all disciplines in the healthcare setting are being called to respond and collaborate together to improve the quality of patient care. In addition to such multidisciplinary approach, information technology is now also included as the most vital element in assisting to avert unnecessary readmissions. The healthcare systems are now exploring the importance of errors in development of a model for predicting 30-day all-cause readmission risk of patients in reducing readmissions. Literature summarized the development of all-cause hospital readmission risk prediction models that examined information technology's ability to use data from errors in predicting readmission patient risk factors, but limited research identified the impact of errors on reducing avoidable admission. Although such models do not include readmission prevention and reduction intervention, they provided early identification regarding high-risk patients, which in turn could begin the process of early intervention to prevent patient readmission. Theoretical framework: multidisciplinary approach, patient-centered approach, early detection plus early intervention equal to reduction in readmission rates. All Medicare inpatients' data in the assigned medical facility will be linked and analyzed. Eligible patients enrolled in fee-for-service Medicare for at least 30 days after the index hospitalization and were discharged home from the assigned medical facility will be evaluated if a patient had multiple hospitalizations. We will select the first as the index hospitalization. Patients who are elective readmission visits, transferred to psychiatric facility, discharged to a skilled nursing facility, and/or hospice care will be excluded. The AIR system will gather and transmit data into the selected predictive model, the Project Boost Inserter, as soon as a patient is admitted to hospital. Data will be analyzed in Cerner based on CMS criteria, and patient information will be divided into different levels. High-risk patients for readmission will be highlighted and an alert will be sent to the Readmission Reduction Care Team portal. Case manager will be assigned and patient-centered multidisciplinary discharge plan of care started. 1. Preparation phase. Identify project team member and readmission reduction care team members. Assign roles and responsibilities during the project. Educate team members regarding the project. Identify and select predict model, the Boost Inserter. Design and modify model to fit the facility. 2. Admission phase. Initiate admission assessment as soon as possible. Utilize Cerner to identify patients in need of post-hospital care and discharge planning. Refer at-risk/high-risk patients to the Readmission Reduction Care Team to initiate a care plan, such as provide appropriate services and intervention. Prepare and educate the patient and family/caregiver for discharge. Medication reconciliation to address any discrepancies. 3. Hospitalization phase. Utilize patient-centered approach to set goals for care and education interventions. Utilize multidisciplinary approach. Educate and empower patient and caregivers. Perform repeat risk assessment to identify change/new risk factors. 4. Discharge phase. Provide patient-centered discharge instructions. Provide timely and thorough communication, oral and written, regarding post-hospital care plan. Discuss post-hospital needs and concerns with post-hospital care providers and as well as patients. Ensure thorough medication reconciliation at discharge. Utilize teach-back approach to ensure patient and family/caregivers understanding of care plan. Implement interventions after discharge, such as early post-discharge follow-up phone calls within 48 to 72 hours to reinforce discharge instructions. Early planned transition care between hospital to home, such as home health referrals. Early post-discharge follow-up with primary care provider within 7 days. Make collaborations and communication easier between multidisciplinary departments, and etc. Reduce readmissions. Identify patient at risk for readmission based on CMS criteria. Utilize Cerner to alert and care team that patient at risk for readmission. Place patient into the patient-centered multidisciplinary discharge care plan. During this project, we understand our strengths and weaknesses, the systems, and responsibilities. In reducing the hospital readmission rate, hospitals' participation in the project implementation is significantly important. Information technology, such as Cerner, becomes essential element due to its impacts on readmission risk factors prediction and early prevention interventions, and the commitment of the readmission reduction care team is vital.